So, good evening, everyone. Respected Kalpana Madam and senior members of the IAP family. I welcome all the members to the yet another program of Tuesday series. And today we have discussing a very important topic of hypertension. And we are also very proud to present our two young speakers in our platform, and we are very happy to hear from them also. And both are IAP trained in SAT as well as in KIMS, and they are classmates also. So very happy to see both in a single day and a single platform. So Dr. Arathi is working with me, and Dr. Shaziya just have so few words. So I welcome Kalpana Madam to introduce the speakers and to for further proceedings.
So actually May 17th is the World Hypertension Day. And so we thought a talk on hypertension. It's quite a long time that we have discussed on hypertension. And I'm so happy that it is two of my dear students. And both of them are doing very well in their profession. And Dr. Arathi Raj is our assistant professor in SAT Government Medical College, Thiruvananthapuram. And first we will listen to Dr. Arathi on how to approach the case of hypertension, and then Dr. Shaziya will be talking on the emergencies. So, is there any, and Dr. Binu, is there
Hi, ma'am. Nothing much to say, ma'am. We can start.
Okay, thank you. So, over to Dr. Arathi. Can you share your screen?
Yes, ma'am. So, thank you, madam, for the kind words. So, I would like to thank IAP Trivandrum, Kalpana madam, Srejit sir, and all the members of the IAP Trivandrum family for giving me this opportunity. And very good evening to my teachers, seniors, colleagues, and dear postgraduates. So, we'll directly move on to the topic. The topic today for discussion is how to evaluate a case of pediatric hypertension. So the ancient records of hypertension stretches for over 4,500 years. The early documented record of elevated blood pressure was given in this Chinese Yellow Emperor's Classic of Internal Medicine, which was around 2600 BC. 3 millennials later, Sir William Harvey described the cardiovascular system, and he focused how the blood flows through the blood vessels. It was in 1733, an English clergyman, Stephen Hales, he was the first one to actually measure the blood pressure on a horse by inserting a glass tube into the artery of the horse and observe the rise and fall of blood in the tube. And another major milestone in the history of hypertension was the invention of cuff-based sphygmomanometer by Rivaroli. Now, what is the prevalence of pediatric hypertension? Nelson quotes the prevalence to be less than 1%, whereas the latest American Academy of Pediatric update in 2017 says the prevalence to be around 3 to 4%. And this increased prevalence may be contributed to the increasing obesity pandemic. This is a data, this is a meta-analysis of prevalence of hypertension among children and adolescents in India, which was published in 2021, which says the pooled prevalence of hypertension to be 7%, whereas sustained hypertension was found to be 4%. And it was found that around 21% of hypertensive children were overweight and 29% were found to be obese. So this shows that there is an association between hypertension and obesity. Now, when to screen the blood pressure in children? So AAP recommends that the blood pressure has to be measured annually in children more than 3 years, whereas the European Society of Hypertension recommends the blood pressure to be measured at every healthcare visit in children over 3 years of age. In children less than 3 years, the blood pressure screening has to be done in high-risk conditions like preterm babies, children with congenital heart disease, renal disease, solid organ transplant, cancer patients, children on drugs causing hypertension, certain illnesses like neurofibromatosis, and any condition with elevated intracranial pressure. Now, what is the definition of hypertension? The latest clinical practice guidelines on hypertension by American Academy of Pediatrics 2027 has given the guidelines for definition of hypertension. So in children less than 13 years, normal blood pressure is when it is less than 90th percentile, and in more than 13 years when it is less than 120 by 80 millimeters of mercury. A child is said to have elevated blood pressure if the blood pressure is between 90th and 95th percentile in less than 13 years, and in more than 13 years if the systolic blood pressure is between 120 to 129 and diastolic pressure is less than 80, then it is said to be elevated blood pressure. Stage 1 hypertension, when the blood pressure is between 95th to 95th plus 12 millimeters of mercury, or it is between systolic blood pressure is between 130 to 139 and diastolic is between 80 to 89 millimeters of mercury. And stage 2 hypertension, when the blood pressure is more than 95 plus 12 millimeters of mercury, or it is more than 140 by 90 millimeters of mercury. So before this 2017 update, there was a 2004 fourth working group report, which released the guidelines for screening and management of hypertension. But this 2017 update is differing from the 2004 update because the revised normative blood pressure value is 2 to 3 millimeters lower than the fourth report. Why is it so? Because in the fourth report, the normative blood pressure values were derived from both normal weight children and in obese and overweight children. But this 2017 update, here the normative blood pressure values are derived excluding the overweight and obese children. So it included children only with the normal weight. And another change in this 2017 update is that the earlier terminology of pre-hypertension is replaced by elevated blood pressure. And there is also a revised definition of left ventricular hypertrophy in the diagnosis of target organ damage in hypertension. Now, these are the blood pressure reference values based on the age, sex, and height of the child, which is available. And this new 2017 update has also given a simplified screening table to identify children with elevated BEP, which requires further evaluation. That means this table can be used as a screening tool in office practice. See, this has got age wise cutoff for elevated blood pressure. So any child with this cutoff has to be screened for blood pressure, hypertension. I'm not saying that this is the cutoff for diagnosing blood pressure. Any child who comes with a value more than this or at this particular age has to be screened for, and further evaluation has to be done. Now, how to measure blood pressure in children? The preferred method is auscultation by using a sphygmomanometer. An appropriate size cuff has to be used. The child should be preferably in seated position, and he should remain calm and quiet for at least 5 minutes before measuring the blood pressure. The right arm is preferred, and the arm should be supported and should be at the level of heart. In case we get an elevated blood pressure recording, 2 additional recordings have to be taken in the same visit, and the average value has to be taken as the final record. Now, how to select an appropriate size cuff? We all know that the cuff has got a bladder inside it, and the bladder should cover the 80% of the circumference of the mid-arm, and it should cover the 40% of the length of the arm. That's how we have to take the appropriate size cuff, and these are the various sizes cuff available. The blood pressure by palpatory method is approximately 10 millimeter lower than the auscultatory method. And now the latest automated blood pressure recording devices are there, which are oscillometric devices, which is a non-invasive technique used to measure blood pressure using a cuff and a pressure sensor. But the problem is that it does not give the actual value. It measures the mean arterial pressure, and then it back calculates the systolic and diastolic blood pressure with an algorithm. And each device has got a different algorithm, hence there is not a specific cutoff for oscillometric devices. And now comes the ambulatory blood pressure monitoring. So here the patient wears the device throughout the day, and the blood pressure is recorded every 20 to 30 minutes. So we tend to get the trend of the blood pressure value of a patient throughout the day. So 2017 American Academy of Pediatric guidelines strongly recommends the use of ambulatory blood pressure monitoring in all cases of elevated blood pressure to confirm the diagnosis. Now, what are the advantages of ambulatory blood pressure monitoring? It helps to confirm hypertension in certain spurious cases. Then it helps to diagnose special conditions like masked hypertension, white coat hypertension. In certain hypertension which are refractory to treatment, to know the effectiveness of drug, we can use this ABPM, and also to know the blood pressure pattern in high-risk patients like chronic kidney disease, CHD, etc. Now, coming to the etiology of hypertension, the hypertension can be either primary hypertension or it can be secondary hypertension. Primary hypertension when there is no identifiable cause. A secondary hypertension when the hypertension is due to the underlying disease process. Now, primary hypertension is usually seen in an older school-going age group. The child will be usually an obese or overweight child. There will be a strong family history of hypertension, but the BP will be at or slightly more than 95th percentile for the age. That is, in primary hypertension, there will be only usually more borderline elevation of blood pressure. And the causes of primary hypertension has been multifactorial, can be due to obesity-related changes in the physiology, pathophysiology, then genetic alteration in sodium and calcium channel, vascular smooth muscle reactivity, abnormality in the vascular smooth muscle reactivity, abnormalities in the RAS system due to sympathetic overactivity, insulin resistance, and even elevated uric acid levels have to be shown to be associated with the hypertension. Then, contrary to primary hypertension, secondary hypertension is usually has a younger age of onset, and the BP will be severely elevated, or the patient will have a symptomatic hypertension. And most common cause of hypertension in infants and children is secondary hypertension, of which the most common cause is renal. The secondary hypertension can be a case of chronic hypertension, or it can present as an acute or intermittent hypertension. So there are various causes of chronic hypertension, of which renal is most important. It can be due to recurrent pyelonephritis, chronic glomerulonephritis, due to structural anomalies of kidney. Then vascular causes like coarctation, renal artery abnormalities due to umbilical artery catheterization, etc. Endocrine causes like Cushing syndrome, then hyperthyroidism, pheochromocytoma, and other monogenic causes of hypertension. Then central nervous system causes, including sleep disordered breathing, can be a cause of chronic hypertension. Then these are the causes of conditions that are associated with intermittent or acute hypertension. They can be renal causes like acute post-infectious glomerulonephritis, HSP, nephritis, hemolytic uremic syndrome, or any condition producing AKI. Then drugs like corticosteroids, sympathomimetic drugs, anti-cancer drugs, then nervous system causes like any condition producing raised ICP, autonomic dysfunction, and miscellaneous causes which includes pain and anxiety. Then there are two entities, that is masked hypertension and white coat hypertension. The masked hypertension is when the office BP is less than 95th percentile, but the ambulatory BP will be more than 95th centile. That means the patient, when he or she comes to the doctor, the BP will be normal, but at other times the BP will be elevated. So there is chance that we miss this case of hypertension. Then white coat hypertension is when the office BP is more than 95th percentile, but the ambulatory BP is less than 95th centile. That means the patient, when he comes to our hospital or to the doctor, we'll diagnose, he will be having elevated BP, but at other times the BP will be normal. This will maybe due to anxiety. So we tend to overdiagnose hypertension. So both these conditions have to be addressed. Then hypertension is in preterm may be due to umbilical artery catheterization, due to bronchopulmonary dysplasia, renal artery or vein thrombosis, etc. And causes in early childhood have already been discussed. Coming to clinical features, already discussed, primary hypertension is usually asymptomatic because there is only borderline elevation of blood pressure and it will be detected only during routine examination. So there will be only mild elevation of blood pressure. The child tend to be obese, but even though the patient may be asymptomatic, there will be evidence of subclinical hypertensive target organ damage in the form of left ventricular hypertrophy, hypertensive retinopathy, increased carotid intima media thickness. Then clinical features of secondary hypertension will be based on the underlying disease. So the child will be having the features of underlying disease like chronic kidney disease, then left ventricular failure, then features of endocrine disease, etc. And because secondary hypertension will be usually symptomatic hypertension, there will be clinical features of target organ damage like left ventricular hypertrophy, congestive heart failure, features of chronic kidney disease, features of hypertensive retinopathy, cerebrovascular accidents. Now, how to approach a case of hypertension? We have got a patient with elevated BP. We have to confirm that it is sustained elevation of hypertension. It is not white coat hypertension. So for that, we have to have multiple readings. And we may also, now that the AAP recommends the use of ambulatory blood pressure monitoring, we can use that to confirm there is hypertension. Then we have to take a proper history. We have to examine the patient and then we have to do the relevant investigations. The investigations are under 4 tiers. That is, we have to do the investigations for identifying the cause, to evaluate any associated comorbidities, to evaluate for the presence of any target organ damage, and additional evaluation as indicated for relevant cases. So in history, there will be history or signs and symptoms of symptomatic hypertension like headache, vomiting, seizures, weaknesses, visual disturbances, bleeding manifestations. Then there can be features of edema, weight loss, failure to thrive as in a case of chronic kidney disease, cold extremities or features of claudication as in coactation of aorta, dysuria, polyuria, hematuria as in case of renal disease, palpitation, sweating, paleness, flushing in case of a pheochromocytoma, virilization, primary amenorrhea, male pseudohermaphroditism in conditions affecting adrenal. Then life history, in birth history, you have to ask whether the child was a preterm baby, whether there is any history of umbilical artery catheterization, family history of hypertension, any coronary artery or cerebrovascular accidents, then any underlying kidney disease has to be asked upon. And detailed personal history has to be taken like eating habits, sleep patterns, any history of substance abuse or smoking. Then in examination, General examination, we look for there any evidence of syndromes like syndromic facies, whether there is any pallor, edema, features of rickets. These are all seen in chronic kidney disease, and edema is seen in renal disease. Then Cushingoid features, neurocutaneous markers are present or not. Then anthropometric measurements is very important because growth retardation is seen in chronic kidney disease, whereas truncal obesity is seen in Cushing syndrome. Then vital examination, the lower limb pulse will be feeble in case of coactation. Tachycardia may be seen in pheochromocytoma, neuroblastoma, and all four limb BP has to be taken because in coactation, the lower limb BP will be lower than the upper limb BP. In systemic examination, you in the abdomen, you have to look whether there is any mass, whether there is any organomegaly, any bruit is there. Then cardiovascular system, you have to check whether there is any murmur, any features of left ventricular hypertrophy like heaving apex, any features of heart failure. Then genital examination to look whether there is any ambiguity, skeletal examination, the neurological examination, whether there is any features of stroke like weakness, cranial nerve palsy, and also a fundus examination to rule out the changes of hypertensive retinopathy. Then specific conditions, the stigmata of specific conditions or syndromes has to be looked upon depending on the case, like neurocutaneous syndrome, genetic conditions like Turner, Williams syndrome, endocrine causes like Cushing syndrome or CAH, and vasculitic syndrome diseases like SLE, HSP has to be looked for. Now coming to the investigations, as already said, investigations are under 4 tier. So first one, we'll do the investigation to find out any identifiable causes. So in a complete blood count, if there is anemia, point into it favors CKD, chronic kidney disease. Then RFT, renal function test, urine analysis and urine culture, electrolytes. This will all give to a clue whether there is any underlying renal disorder or any mineralocorticoid excess disorder, as evidenced by hypokalemia. Then renal ultrasound will show any evidence of renal scar or any congenital anomalies, or if there is any renal size discrepancy, which will indicate that there is a renovascular cause for hypertension. So the renal and renovascular hypertension is the most common cause of secondary hypertension in pediatric age group. So there will be discrepant kidney size on ultrasound, hypokalemia, and an epigastric bruit or abdominal bruit will be there on examination. Now coming to the evaluation of any associated comorbidities. So if the patient is obese or we are suspecting primary hypertension, then you have to screen for any dyslipidemia, diabetes mellitus by looking for HbA1c and blood glucose level, and any features of fatty liver by looking AST, ALT. Then drug screening has to be done if you suspect any substance abuse, and polysomnography in cases of sleep disordered breathing. Then evaluation of target organ damage by performing an echo, where if there is persistent hypertension, there will be features of left ventricular hypertrophy, and other cardiac conditions causing hypertension like coactation can also be screened. Retinal examination to see whether there is any retinal vascular changes. So the definition of left ventricular hypertrophy in echo, according to the latest AAP guidelines, is when the LV mass is more than 51 gram per meter raised to 2.7 in children more than 8 years, or when in children less than 8 years, the left ventricular mass is more than 115 gram per body surface area in boys and more than 95 grams per body surface area for girls. If there is evidence of left ventricular hypertrophy in the initial echo, the follow-up echo for the progression of this hypertrophy has to be done at an interval of 6 to 12 months. And if there is no evidence of target organ damage, that is, there is no LVH in the initial echographic assessment, then follow-up echo has to be done yearly in stage 2 hypertension or secondary hypertension or chronic stage 1 hypertension. Then additional evaluation if needed according to the case. Suppose we are suspecting white coat hypertension, or in a case of pheochromocytoma where there is abnormal diurnal blood pressure patterns, you can use an ambulatory blood pressure monitoring. If you are suspecting renovascular disease, that is, there is a discrepancy in the kidney size in an ultrasound, then you have to do the renovascular imaging in the form of CT angiography and MR angiography. CT angiography is more sensitive than MR angiography in identifying a renovascular cause. Then if you suspect hyperaldosteronism or monogenic hypertension, then you can do the plasma renin activity and aldosterone renin ratio. Then if you are suspecting pheochromocytoma, then you can send a plasma and urine catecholamine levels. So this was about evaluation of a case of hypertension. Now that you got the cause, you can proceed to the treatment of hypertension. So if this is elevated BP, then you will advise lifestyle modification, then recheck the blood pressure after 6 months. If still after 6 months the blood pressure is elevated, you have to check all forelimb BP. Then if it is normal, you continue lifestyle modification and recheck the blood pressure after 12 months. And if still after 1 year of lifestyle modification, the blood pressure is still elevated, you have to do an ambulatory blood pressure monitoring to know the trends of blood pressure values, and you also have to do the diagnostic evaluation to know whether there is any underlying disease. Anytime the blood pressure returns to normal, then annual blood pressure screening, as already discussed, has to be done. Now, if it is stage 1 hypertension, it is if the patient is asymptomatic, again, you will advise lifestyle modification and we'll recheck the blood pressure and recall them after 1 to 2 weeks. If the BP is still elevated, you check the all four limb BP, continue lifestyle modification, recheck after 3 months. And if even after 3 months, BP is elevated, you do an ambulatory blood pressure monitoring, you do the diagnostic evaluation to identify the cause, you do the target organ damage screening, and you will start treatment if needed, if it is persistently high. Stage 2 hypertension, if it is asymptomatic, again you'll start lifestyle modification and recheck BP within 1 week. And if it's still elevated, you have to do ambulatory blood pressure monitoring. You have to identify the cause for it and start treatment, and subspecialty referral to screen for the target organ damage. And if it is symptomatic stage 2 hypertension, or if the blood pressure is 30 millimeters above the 95th percentile, or BP value more than 180 by 20 millimeters of mercury, immediate referral to an emergency department, because this will be treated as a case of pediatric emergency. Now, what are the goals of therapy? The goal is reduction in systolic and diastolic BP to less than 90th percentile or less than 130 by 80 in a child more than 13 years of age. Now, what are the lifestyle modification or the non-pharmacological interventions to control hypertension? There is diet, physical activity, weight loss strategy, and stress management. So the diet to control hypertension is given as DASH, that is dietary approach to stop hypertension, where all these items are given according to these servings per day, recommended servings per day, with the salt in controlled manner, less than 2.3 gram per day. So this is the DASH diet, that is dietary approach to stop hypertension, which includes high fiber, whole grain diet, low salt and sugar diet. Then physical activity, it is recommended that the child should have at least 30 to 60 minutes of moderate to vigorous physical activity at least 3 to 5 days a week. And if the child is obese, then weight loss strategies has to be taken care of, like in vigorous exercise, dietary modification, etc. And then stress management in the form of yoga and medication. Coming to the pharmacological treatment, there are 4 groups of drugs which are used, that is AC inhibitors or ARBs, calcium channel blockers, diuretics, and beta blocker. Of these, ACE inhibitors, calcium channel blocker, and diuretics may be used as the first line treatment. Diuretics, especially in a case of kidney disease with the fluid retention, where normally AC inhibitors and calcium channel blockers are given as the initial drug. Beta blocker is not started as an initial drug for the treatment of hypertension in pediatrics. Then AC inhibitors and ARBs, they have additional anti-proteinuretic effect. The AC inhibitors can be given only if there is no bilateral renal artery stenosis. That is, it is contraindicated in bilateral renal artery stenosis. Then AC inhibitors are teratogenic, hence should be used in adolescent girls in the child-bearing age group. Then the drugs approved are enalapril, captopril, and fosinopril. Then calcium channel blockers, commonly used are nifedipine and amlodipine. They have the adverse effect of flushing, headache, edema. Then diuretics, commonly used as loop diuretic and thiazide diuretics. And as already said, beta blocker is not used as first line, may be used as an add-on drug, but it should not be used in a case of asthma. Then AC inhibitors and ARBs, that is angiotensin receptor blockers, are preferred in hypertension due to chronic kidney disease, diabetes, or any condition producing proteinuria. Then beta blocker should not be used as an initial treatment, and the single drug is added in the minimum dose, and the dose is increased every 2 to 4 weeks till it reaches the maximum dose and the BP is controlled. If BP is not controlled with a single drug, you can add a second drug. Now, what is resistant hypertension? Persistently elevated blood pressure despite 3 or more antihypertensives of different classes, of which one group is a diuretic one. So, in such patients, you can use other drugs like alpha blocker, alpha plus beta blocker like labetalol, direct vasodilators, potassium sparing diuretics like spironolactone. Then you have to treat the underlying cause in a case of secondary hypertension. Then prevention of hypertension is by a proper good diet, then regular physical activity, low sodium diet, stress management, a good sleep, and avoidance of substance abuse and tobacco smoking. Then, as Madam said, the World Hypertension Day falls on May 17, and this year was the 20th anniversary of the celebration of World Hypertension Day. And the motto of this year was measure your blood pressure accurately, control it, and live longer. Thank you.
Thank you, Arathi. That was a very good, very good talk, and we could refresh. Actually, after many, many years, I am hearing about hypertension. It is very clear and precise presentation. There are a few questions in the chat box, mainly regarding the yoga. Is there any studies to prove benefits in stress management? Yoga and the
in this age, American Academy of Pediatrics, they have said that few studies have shown that yoga and meditation has shown to decrease blood pressure values.
I think we should keep the pediatric and adult out. Yoga stress comes in the adult population, I think, mainly. Pediatric is entirely different.
Pediatricians or pediatric people, children also have stress, a lot of stress. And our dear Ashok sir is here. Sir, can you say a few words?
So, Aarti, very good presentation. Congratulations. And one entity you did not mention is Takayasu's disease, vasculitis, which can produce hypertension, especially if you have to check the blood pressure in various limbs. Sometimes some limbs, the blood pressure may be low. So Takayasu is one condition which I have seen rare, which produces. I thought it was coarctation, but turned out to be Takayasu. One another rare case which I have seen is facial palsy as a presenting symptom of hypertension. I thought I was thinking of an intracranial lesion or something like that, but turned out to be a hypertension due to renovascular disease producing facial palsy. So facial palsy rarely may be a presenting symptom. Our biggest problem is how many of us do blood pressure measurements in children in the outpatient. Very rare. One thing is it's a bit difficult to keep the child quiet. Second is we don't get the appropriate size cuff. Very difficult to get it. How many OPs have the appropriate size cuff? So it's important, but very rarely we check their blood pressure either annually or once in 5 years. Very rarely done, but we must probably do it more frequently and make the appropriate size cup more easily available. Well done, Arathi.
Thank you, sir. We recently had a case of Takayasu in our SAT. She had the pulse difference in both limbs.
So, Dr. Shanavas, is there? Dr. Shanavas, please. Shanavas.
Good evening, madam. So I have heard the talk. Very interesting talk on detailed description regarding very clearly described. As Ashok Kumar sir told, we don't have the habit of looking BP. So we should have the recommendations, how many recommendations, American recommendation, European recommendation that Arathi has clearly described. We should have the habit of looking. Sir used to tell. So when he was working in UK, he used to examine each patient here using otoscope. Just like that, we should also have the habit of taking BP. So we used to tell all our pages, at least all our admitted patients should have one BP. Nowadays, it is more they are looking. So we should have the habits. So very well presented, Arathi. Thank you.
Thank you, sir.
Purushothaman sir, it's quite a long time that we met sir in this Tuesday webinar. Purushothaman sir is there?
Yes. Arathi presented very well. Regarding the initial part in the methodology, method of measurement, at least once you should be measuring all four limbs. You mentioned in the approach part, but in the method, that should be stressed. And one more thing, at least once you should be measuring sitting and standing in all case of BP when you are saying it as abnormal. Then the method of lowering the BP, it should be slow, 2 to 3 millimeters at a time. That is a method of lowering. And the cutoff, which phase of the Korotkov sound you need to mention. It's the fourth phase or the fifth phase. Now it is uniformly recommended as the fifth phase of disappearance. But there are exceptions where you are seeing a muffling followed by a longer time for disappearance. In a case of high pulse volume situations like AR, like some other PDA and all in our pediatric age group, there when you express the blood pressure, you need to mention all the values. The systolic followed by next one, followed by next one. 3 values you need to mention in that blood pressure report. And you already mentioned the height need to be taken into consideration. So that is a standard of this thing. And Ashok Kumar sir was rightly pointing out, you didn't give much stress on the aortic involvement in vasculitis. Coarctation is definitely mentioned. And in the coarctation and in the aortic vasculitis, whenever you see a systolic BP equal in the upper and lower limb also need to be considered abnormal. Because at least 10 difference should be there. Equal also need to be considered as abnormal. And in the large vessel vasculitis, in Kerala, unlike the classical distribution of the Japan, the aortic arch involvement, we are getting more and more case of a descending aorta and abdominal aorta involvement. Maybe that's a variety. Comparatively sparing the upper part and involving the descending aorta more. So importance is that the classical hypertension due to this situation, you can make out by the radial delay or a BP difference between the upper limb, absence of the carotid, and this may not be the difference between the upper and lower limb only. See if it is a descending aorta involvement. More and more cases are there. And the last thing, the difference between hypertensive, urgency, emergency, those terms, you just elaborate on that. Previously, it was hypertensive emergencies and hypertensive urgencies in acute situations. അങ്ങനെ ഒരു കാര്യം പറഞ്ഞിരുന്നില്ലേ?
Sir, next talk is on urgency and emergencies.
Okay. ഞാനത് സോറി. അപ്പം ഓക്കെ നന്നായിരുന്നു.
Krishnan, Dr. Hari Krishnan is there?
Yes, ma'am.
May your comments, please.
Ma'am, just wanted to highlight that you need to adjust the medication doses at each follow-up. What usually happens is we start at a very low dose, and most of us are very reluctant to increase the dose to the maximum required levels. And any case of like unexplained tachycardia, you need to find out a reason. Like I was just telling Arathi only, we had a case where the patient just presented with tachycardia, no hypertension at presentation, and echo was showing some mild LV dysfunction. So we just admitted for evaluation and then did an ABPM, which showed significant intermittent hypertension with tachycardia, and she had a diagnosis of pheochromocytoma. So it's important to find out the cause. And in the chat box, I saw one of them had asked, what is the management of pheochromocytoma? So I would just like to elaborate that particular case, how we managed. We did all the workup. The urine VMA turned out to be negative, actually. Then we had to send the metanephrine level to diagnose it. And then the CT showed a lesion in the adrenal gland. How we managed it is we started an alpha blocker, that is prazosin, and to the maximum dose. The prazosin dose, the tolerated dose is till the patient developing postural hypotension. That is what is recommended. And along with that, you slightly increase the sodium intake so that patient does not develop those postural hypotension symptoms. So you increase alpha blockade and then start a beta blocker. It is not recommended to start a direct alpha plus beta blocker like a labetalol, because the ratio of alpha and beta blockade is different. So you start maximum dose of prazosin followed by a beta blocker like propranolol, and in addition you might require other drugs like nifedipine. So that is how you manage the BP pre-surgery in a pheochromocytoma, and then obviously the tumor has to be resected.
Hari is there. One doubt regarding the echo criteria Ari was mentioning. Is
Yes,
it routinely done? It is a complicated thing, less than 8
No.
years, and that is in the software?
It is not a complicated. Once you do the M modes for ejection fraction, if you actually measure the interventricular septal thickness in diastole, systole, a posterior wall thickness, which is routinely done in adult patients. If you take that cut itself, it gives the LV mass. Only thing, the difference is that you have to change it for the body surface area to see for the criteria. The LV mass comes if you do a routine M mode for ejection fraction.
So you need to calculate based on the weight in kg or surface area based on the less than 8 or more than 8. So that is that.
Yes, sir.
I remember a case when I was there in Trivandrum with Ashok sir. I don't know whether it was during Ashok sir or Noel sir. There was a case of pheochromocytoma at that time. And surgery, it was Hariharan sir at that time. It is very difficult to control. At that time, we used labetalol and beta blockers also. That was, you said that the prazosin was not used at that time. Labetalol was the one used.
Okay. But the ratio of alpha to beta blockade in labetalol is different. We need more of alpha blockade compared to beta blockade.
Labetalol is less of alpha compared to prazosin?
Yes, sir. We had actually started labetalol for that patient and then had to switch over to prazosin plus propranolol.
Prazosin oral or parenteral? Parenteral is available?
Parenteral, I'm not sure. So we had started oral.
Okay.
Dr. Lakshmi? Dr. Lakshmi is there?
Yes, madam.
Please, your comments, please.
As Harry already said, we should always rule out secondary hypertension, especially in small children. And if the hypertension is stage 2, we have several incidences like that. One small baby presented with hypertension, and we could not, initial evaluation was all negative, but we had a strong suspicion that when renal ultrasound was also normal. And in small babies, the renal artery flow is difficult to find out in ultrasound. So actually that child had renal artery stenosis. And so the child had to undergo surgery. So whenever you have a suspicion, you have to go for the next line of investigation. So secondary hypertension should always be kept in your mind when the baby is small, especially in small babies and those with stage 2 hypertension. And regarding pheochromocytoma, actually we have to ensure that all the alpha receptors are completely blocked before starting beta antagonists, because otherwise beta blockers. Otherwise, what will happen? There will be unopposed action of alpha receptors, and the reverse effect will come. That is why we start prazosin initially, and only after the full dose of prazosin is reached, we will start the beta blocker. And labetalol is not now recommended as the initial treatment of pheochromocytoma. And it was a nice presentation, Arathi.
Santosh sir is here. Santosh sir, please.
I'm driving, so I don't know whether I'll be okay. Partially, I heard the presentation and it was very good. Regarding that Takayasu, I think Ashok sir may be able to tell the relation with tuberculosis, because we have seen few Takayasus that we have had, all had mantle positivity, if I remember correct. And then regarding that BP measurement, Dr. Purushothaman mentioned, in case of AR and all, up to 0, there will be tuck like that. So you will have to definitely take the muffling. That's all that I have to say. And congratulations, good presentation.
Thank you, sir.
What Santosh said, I had this Takayasu disease, and the MANDU was positive. Then all the subsequent cases, we checked the MANDU, and all of them had MANDU positive. But they didn't have other features of tuberculosis, but MANDU was positive. So when Dr. Amdekar from Bombay came, he also agreed that there is a association between MANDU and Takayasu. So how exactly it is associated, we don't know.
Thank you, Arathi, for that nice presentation. And we'll go on to the next session on hypertensive emergencies, presented by Dr. Shaziya. She is the consultant intensivist at Maitra Hospital, Calicut, and she is also our student at KIMS years back, and she is doing very well and as an intensivist also. We can listen to Dr. Shaziya. Shaziya?
Yes. My screen is shared.
You can put it in the full screen mode.
Yeah.
Okay.
Thank you, Kalpana. Thank you, IIP Trivandrum. It's my pleasure to present in front of my beloved teachers, my colleagues, my friends today. Actually, Arti has described well about the diagnosis, evaluation, management of hypertension, but often, or I would say, many times, children remain undiagnosed. And they present as hypertensive crisis. So it's very important and it's very interesting to tackle these cases. So we'll discuss in detail the PACU management of pediatric hypertensive crisis. So hypertensive crisis is a life-threatening elevated BP condition where these two entities are there, hypertensive urgency and hypertensive emergency. So this is nothing but hypertensive emergency. The key hallmark point is the involvement of end organs and they will be damaged. And hypertensive urgency, there severely elevated BP will be there without any evidence of end organ damage. So there is no absolute cutoff for BP level to diagnose this urgency or emergency. It's the involvement of acute end organ damages differentiates between these two. But management part actually is same for all, but considering the end organ in the hypertensive emergency management. So end organs are those with having their own auto-regulation so that maintaining blood circulation to those organs. So they are brain, heart, eyes, and kidneys. And hypertensive encephalopathy is most common among all these things. So it can have an incidence onset to very varied presentation. It can present as encephalopathy, reversible encephalopathy syndromes, or even as previously said, cranial nerve palsies, or even with other focal neurological deficits, if it is involving in a severe condition like ischemic events or IC bleeds, or even to diffuse cerebral edema. Then heart can be involved and can present as congestive cardiac failure with without coronary ischemic changes. So myocardial ischemia can happen along with aortic dissection in some defined groups. Hypertensive retinopathy can happen actually usually diagnosed while evaluation, and those are usually asymptomatic. And hypertensive nephropathy. So, what should be our goal of therapy? It should be to attain a systolic BP to promote resolution of life-threatening signs and symptoms, and it should prevent further end organ damage. And that's usually recommended is 90th percentile of the BP for that age, sex, and height. So, but our goal of therapy should not be more than 25% of the difference between current systolic and 90th centile by the end of 8 hours. That means, for example, if a child presents with a crisis and say her current systolic BP was 200 and her required 90th centile is 100, then the 25% of the difference between these two should be attained by the end of 8 hours. And there are dictums like next 8 hours, 25% reduction. And so by end of 48 hours, we get the 90th centile BP. But why should we, advocate these type of management in controlled manner? Because of the permanent damages due to our, rapid falling BP because of the ischemic events that happens in coronary circulation, such as my MI, in cerebral circulation as stroke, and it causes kidney injury because of the auto regulation that I will discuss. But this is not advocated for the management of aortic dissection, where we need a rapid control of systolic BP so that we can reduce the aortic wall stress. So autoregulation is a phenomenon where the blood flow is maintained over a range of map so that organ will get a defined blood flow. So, above the level of autoregulatory range, what happens is there is forced dilatation of the vessels, actually pertaining to that elevated BP. This causes cerebral vascular dilatation, blood-brain barrier disruption, thus increasing vasogenic edema, thus causing the hypertensive encephalopathy. And also another, so what happens is in our management, by rapidly reducing the BP, what happens is BP will fall in the below the autoregulatory change. In hypertensive people, the autoregulatory range shift to right because of their adaptation. So once we reduce rapidly systolic BP, it falls below the autoregulatory range and thus causing vasoconstriction and ischemic events. So that's why we are controlling the BP in a planned manner. So, as in any case, we have to maintain airway, breathing, circulation when a child presents to us with hypertensive crisis. We preferably there should be 2 IV lines if it is good, or otherwise central venous access. So that one should be dedicated for giving IV antihypertensives, and baseline samples has to be get, as Adi was saying, and such complete hemogram, renal functions, electrolytes, glucose, and blood gas if preferably. Then we have to confirm the elevated hypertension. It should be like, it is good that arterial line is there so that we can have a continuous monitoring of BP levels. Or otherwise, if it is not possible, frequent oscillatory method is also advised. And evaluate for end organ damage both clinically and with the help of biochemical and radiological investigations, and find out any possibilities for sympathomimetic overactivity. This I will discuss later. This actually influenced the choice of initial in antihypertensives, as just now was discussing about pheochromocytoma. And after that, we can actually start IV antihypertensives. So we can have many options. Many of us will be, in doubt in selecting this antihypertensives. So we'll be discussing in detail about that. So once it has started, after 6 to 8 hours, we can actually add oral medications. For example, alpha-2 blockade with clonidine, which is an excellent add-on drug. Then calcium channel blockers, beta blockers, ACA and ARBs, if provided renal functions are okay. So that we can taper and stop IV antihypertensives. Why? Because a phenomenon known as tachyphylaxis is happening. So this is nothing but toleration of IV antihypertensives, where after a particular point, the effect is not seen even after increasing the dosage. So de-escalation is also important while managing the antihypertensives. Choices of antihypertensives include, as we said, labetalol, which is actually used universally while managing hypertensive crisis. It is an alpha-1 and non-selective beta-adrenergic blocker. And esmolol, it is an ultra-short-acting selective beta-1 adrenergic blocker. These two are actually sympatholytics. And another options is the hydralazine, which is a direct vasodilator, which affects by influencing the calcium influx and thus having a predominant arteriolar dilator. And nicardipine is a calcium channel blocker with predominant arteriolar dilatation. And another choice would be sodium nitroprusside. This is also another universal drug used in managing this hypertensive crisis when in doubt. It is actually vasodilator with effect on both artery and vein. So here you can see esmolol and nitroprusside is having shorter rapid onset of action with short duration of action. But here, hydralazine has a slower onset of action with longer duration of action. This gives the ease of titration of esmolol nitroprusside. Labetalol has been proven to ineffective reducing blood BP with good safety profile and higher neurological recovery. And but should be cautious while using in children with asthma or bronchopulmonary dysplasias and severe LV dysfunction, heart failure. Esmolol, as I said, it is an ultra short acting selective beta 1 adrenergic antagonist. So it has no intrinsic sympathomimetic activity. So it can cause significant bradycardia, hypotension, and also it has to be used in caution, or it has to be avoided in cases of congestive heart failure and in cases of bronchoconstriction. And also it is not used in pheochromocytoma because it is a selective beta 1 adrenergic antagonist. Because of the unopposed alpha action can result in heart failure. So used cautiously. But esmolol has a good role in controlling the hypertension in post-cardiac surgery patients. So another option would be nicardipine, as it is a calcium channel blocker causing smooth muscle relaxation and arterial dilator. And it is easily titratable, but it causes reflex tachycardia. But its use is very much explained in infants. Sodium nitroprusside is a first-line medication in most hypertensive crises. It is a non-selective vasodilator with effect both in artery and vein. It has a rapid onset of action with with good ease of titration. And once it is discontinued, there is rapid dissipation of its effects. Why? Because it has a metabolite thiocyanate, which causes toxicity while having renal failure. Also, it causes methemoglobinemia and cyanotoxicity while continuous overdosage. And this is the dosage range for these antihypertensives. And in this, you can see labetalol and hydralazine can be used as a bolus also. Rest we can refer and start. But once we are selecting a particular agent, start at low dose, titrate it. And if the child is needing higher dose of that, and or if the child has adverse effect of that, then you can definitely add another IV antihypertensive and titrate accordingly. And with start of oral agents, we can definitely taper off. Apart from IV antihypertensive, we can have diuretics for help in cases of children with fluid overloaded, especially in CCF or renal diseases, and also with help of RRT in case of renal shutdown. Coming to the causes of hypertensive crisis, usually in pediatric age group, as we already told, essential hypertension or primary hypertension is very rare. Causes of secondary hypertension has to be ruled out. And in PICU setting, I would like to stress on these conditions. As they said, most common causes renovascular, renal structural, and renal parenchymal, such as glomerulonephritis or obstructive renal diseases, reflex nephropathy, vasculitis, and renovascular renal artery stenosis, renal vein thrombosis. And other cohort would be adrenal and neuroendocrine tumors. So adrenal adrenal hyperplasias, Cushing's, neuroendocrine tumors such as pheochromocytoma or differentiated and undifferentiated ganglioneuroblastomas, and thyroid crisis. And many of the cohort will be drug induced, especially if the child is on steroids, or some cohorts we are getting mainly from hemato-onco ward following chemotherapeutic drugs or even after immunosuppressant drugs, and following envenomation, especially scorpion stings, and also overdosage of sympathomimetic agents like cocaine. So all these should be in your mind. So we'll discuss some cases. So recent cases we had to encounter. So this is a story of 12-year-old girl presented with epistaxis, hemoptysis, confusion. So she presented with acute hypertensive crisis. She was also actually non-development case of non-developmental delay and intellectual disability with the non-canotype abnormality. She presented with us BP of 240 and 160. So this is the current systolic BP, right? So we have to have a BP target. So by 8 hours, we say for 90th centile for this girl is 120. So the difference between 120 and 240, that's 25th percent would be around 200. So we can have a target value of systolic BP by the end of 8 hours would be 200. So support airway breathing circulation. We started on actually on IV sodium nitroprusside and evaluated for end organ damages. And she had refractory accelerated hypertension, nearly requiring 48 hours of antihypertensives. And we added multiple oral agents. And she also had hypoxia and respiratory distress because of the left lobar collapse. And left lobar collapse. She initially was managed with NIV. And evaluation was done as already discussed, but everything was okay except for the persisting proteinuria in after controlling the BP. So I'm pointing towards that. And this about the hypoxia part, as we done CT that showed a cutoff at the level of left main bronchi, and you can see here. And this bronchoscopy was done after controlling the BP, and it revealed a large clot in the left main bronchi, and it was retrieved. So you can see the large formed clot has retrieved from the left main bronchi. So all these, along with we have done renal biopsy that showed a parenchymal disease, FSGS. Prognosis was explained, and the skid was tapered from the antihypertensives, and oral agents were adjusted. And so why I told this like to manage ABC thing along with the hypertensive crisis. Another story of a 7-year-old girl with a decompensated chronic liver disease, the non-diagnosed chronic progressive familial intrahepatic cholestasis. She underwent liver transplant here and was on tacrolimus. She presented to us with seizures and poor activity. On arrival, she was seizing, and as management part, we secured airway, maintained the breathing and circulation. Line access was made and reassessed it, and as the child was continued to have seizures, and seizure medication was given, and the imaging showed this as a T2 MRI image, T2 image, flare image showing the hyperintense lesion in the occipital region. This is done once child is stable. CT was okay. Brain was okay. So this is a clear-cut case of hypertensive encephalopathy present. Actually, it can have incidental onset of symptoms like headache, nausea, vomiting. Can present as altered sensorium as seizures here, and also with neurological deficits, cortical blindness, and if untreated, they can progress to cerebral edema, causing coma and death. Usually, they present with non-localizing symptoms, and this reversible encephalopathy usually affect the posterior circulation but can affect any area of the brain. So here pathology is explained as loss of cerebral autoregulation. Both the extreme side of autoregulation are being explained, and these areas in dispute regarding the pathology of encephalopathy. But this should be differentiated from the Cushing's reflex of the raised ICT, because here the management is entirely different. We don't rapidly reduce, or even we don't mind in reducing hypertension because we have to manage ICP here. So MAP has to be maintained. So other end organs, hypertensive nephropathy usually presents as proteinuria, hematuria. Usually it's resolving, but may need RRT in case of renal shutdown. Hypertensive retinopathy is usually symptomatic in 50%, while evaluation we see this vascular changes. So another story of a 6-year-old girl presented with a visual disturbances, respiratory distress requiring positive pressure ventilation, and echo showed poor LV function LVH. The X-ray showed pulmonary edema, and this is the echo showing poor LV function, and this we can see B lines in the lung ultrasound. So she presented with a hypertensive crisis, CCF, and evolving breath. Antihypertensives were started. And along with antidiuretics, here comes the role of IV diuretics as child is fluid overloaded, and it helps the congestive cardiac failure part. And on evaluation, she found USG abdomen was done, that was showing left-sided small-sized kidney, and renal artery imaging was done, was showed renal artery stenosis, and renal artery stenosis was done. So here comes the role of definitive management and proper evaluation, so that we can have a definitive management in such cases rather than giving medical. Another story of 2-year-old boy. Actually, he presented to us as seizures for evaluation. He was referred intubated for an acute life-threatening event. And on evaluation, he found to have there is stroke, rapid onset obesity, hypoventilation, and this time child had hypertensive crisis. And antihypertensives were started with along with oral multiple agents. MRI brain was normal, so this was not hypertensive encephalopathy. And MRI abdomen surprisingly showed T2 hyperintense salt lesion in the aortic cable region. So you can see here more clearly in the next slide, I think. It's a PET scan showing the lesion in the aortic cable region. So excision was done, post-op was maintained with the antihypertensive. As said, this is also suspected neuroendocrine tumor. So proper alpha blockade was done. After that, beta blockade. Then excision post-op was okay. Then this hypoventilation was tackled with the tapering BiPAP support. And histopathology turned as ganglioneuroblastoma. So it also comes the role of proper evaluation and definitive management, and this actually turned as a Rohart syndrome. And this is a tale of another 3-year-old girl presented with a headache, confusion, vomiting, seizures, presented as hypertensive crisis. And this was turned as a post-epilocal glomerulonephritis, where kidney was actually shut down, so RRT was done. So all these cases were showing the importance of management of acute crisis, so that we can salvage the end organs and other functions, maintaining the airway, breathing, circulation, and the importance of evaluation at the PICU itself, so that we can get done definitive management. So these are my take-home messages. Make sure airway, breathing, circulation is maintained. Evaluate for target organ damage, so that we can differentiate urgency and emergency. And it's better to advocate controlled BP reduction with good choice of antihypertensives, and start with low dose, then titrate if requiring. We can definitely add on with other antihypertensives and also with oral agents, so that we can titrate accordingly. Then at the same time, evaluate for severe hypertension if it is refractory and requiring high doses. And definitive treatment is mandatory for successful control of crisis. Thank you.
Thank you, Shaziya. That was an excellent presentation along with her own cases. So many interesting cases we could listen to, and it is very good. And I'm still remembering the frail Shaziya joining as the first year resident in KIMS, and she was not even talking at all. And actually, our Ashok sir is instrumental in making her like this. Ashok sir, for a few words. Ashok Kumar sir. Ashok Kumar sir is there.
Hello, Shaziya. Good to see you again after a long time. So, a very nice presentation. I remember you are a good cinematographer, no?
Yes,
you used to
yes.
take nice pictures with your mobile camera. Second thing, have you ever had to use IV magnesium sulfate? Or is there any role for IV magnesium sulfate?
I didn't use it for hypertensive crisis, sir, but definitely it will, cause smooth muscle relaxation will help.
Because I don't know whether you were there, we had a case of tetanus under Dr. Jairamdas, and because of the sympathetic overactivity and child developed intractable hypertension, and this was one of the choices we thought of giving IV magnesium sulfate.
Okay.
And now, because the BP measurement is always there in ICU, actually, in children admitted to ICU, we are not missing hypertensive emergencies. Previously, it was like any child coming with seizures or with visual impairment or whatever it is. Sometimes, after the MRI, which is showing the press, we had actually gone back and took the BP. There are incidences like that. So, BP checking in all the cases is absolutely essential, and that is one point that I wanted to say. And definitely the end organ should be taken into consideration. And Dr. Rathika is there because so many renal cases have been presented, isn't it? Dr. Rathika? Rathika is there?
Not there, madam.
Rathika Radhakrishnan, her name was there in between. Dr. Shiju?
Ma'am, Shaziya well presented, Shaziya. I think she emphasizes the importance of ABC, but it's really stress there because even somebody is coming with a GCS of less than 8, we may need to intubate and initiate neuroprotective measures. Okay.
Yes.
So BP measure to control it may take actually 24 to 48 hours. Recently, we had a patient, 4-year-old with a blood pressure of 260 by 160. Okay, he came with a seizure, had to intubate. It almost took 24 hours to reduce by 25%. So it was very challenging, but neuroprotective measures like head end elevation, keeping the blood pressure slowly reducing, avoiding hypoxia. So that are very important to prevent the secondary damage. So I think she's plus. Again, the drugs used, labetalol, magnesium sulfate, I don't think it is in the guidelines currently. We have not used it so far. SNB is there, then NTG is there. So these are the other tools, drugs we can use.
This magnesium sulfate, we are just thinking because in gynecology for eclampsia, they were using magnesium sulfate for treatment of eclampsia. So we are thinking, why don't we also give a try? But we did not ultimately use it. We are scared because there are no published reports of giving magnesium sulfate.
We'll look into it, sir. I don't remember any.
There are two questions in the chat box. One is Dr. Fatima is asking when we will start the oral drugs after control of hyper, or till what time we will use IV and when you will start the oral.
So along with the IV antihypertensives, say even after 6 to 8 hours of starting IV antihypertensive, we can start oral agents, preferably calcium channel blockers or clonidine. Yeah. So it's need not to be, wait to start oral agents for 2 days after completely, managing the hypertension. Along with IV antihypertensives, we can start oral agents, and it helps in reducing the dose of this continuous IV infusion. So we can, easily shift out from the ICU.
And one more question is how to manage the hypertension and drug addicts.
Usually, sympathomimetic agents overdoses can happen, so they present in more of sympathetic drive. So, alpha plus beta blockage we can give. So, labetalol can be used.
Yes, yeah. Yes, yeah, that is an excellent cases you had. Few cases in the newborn patient presenting with seizures. We are all considering secondary causes. Few of them very difficult or very likely to miss are 17OH type of CH. So you should always keep in mind that possibility, because there is no genital change, nothing else will be there. The only clue will be the serum electrolyte pattern. Potassium on the lower side and sodium on the higher side in a female child presenting with disease, always make it a point to measure the BP. That is a one entity in the newborn baby. And that the very same thing can happen in an adolescent or older age group, again presenting with hypertension only. Variants of CH need to be considered. In the adolescent, two more entities. You said the cocaine. Our use of cocaine in our own students are not that high, but you need to consider that possibility. And here in the general examination, in the skin, we need to look for skin prick always of the use of the drugs. The second one, priapism is very, very important. When a patient is brought with hypertension, that's a clue, because among all the drug you listed, the prazosin is the only situation, only drug of choice which will work. It is a standard of care now from 2004 onwards. We had bad experiences with this snake, these scorpion stings. In the 80s, we had 2 deaths following this hypertension. It is a labile thing. It goes up and goes down. And what should be done? At that time, nitroprusside was the one used, but we lost that patient. And later, 2004, Mahadevan sir's report from Pondicherry, we were using prazosin. The importance is that few of the situations, the BP may go down and episodically goes high. So will you be able to give the alpha blocker? That is one point. You need to put the patient on alpha blocker broadly, even when the BP is a little on the lower side. Don't hesitate to give prazosin if you think it's a scorpion bite. So clues are always in a male child, priapism is very, very important entity. And on those days, we were seeing any case of acute nephritis with hypertension leading to the hypertension encephalopathy. We didn't know about the MRI picture, and later only, since 2000 only, we had that experience of seeing that press and all. So that was again later onset experiences. And there were cases of neurological problems like GBS also with fluctuating hypertension. And the management you already stressed. One interesting thing regarding the Arathi's presentation, the fundus evaluation in all case of hypertension, it's for the change which you see in the hypertension. There's a diagnostic clue also for Takayasu disease, because Takayasu was described by an ophthalmologist. And there's a typical fundal change in the, this is a diagnostic clue, not an end organ damage. That interesting finding. That is called corkscrew fundus or something like that. That's my memory. Thank you.
Thank you, sir.
Is Dr. Bindu Tangapan there? Dr. Bindu Tangapan, we have seen her quite for
Yes,
quite
madam.
a long time. I have not seen her. Dr. Bindu,
Yes, yes,
your
madam.
opinion. It is very interesting that you came for our presentation.
It was a very education session for me, both
He's a
Aarti as well as
neurologist actually in Chennai.
both Aarti and Shafiya had spoken very comprehensively and concisely. In the teenage group, one of the in between one hypertensive was that if we don't get a clue, we have to ask what all drugs they have been taking, like over-the-counter cough syrups, like which initially was having phenylpropanolamine and so many other pseudoephedrines. All these are hidden causes of hypertension. Sometimes small children, they'll keep on drinking because of the sweet taste. So that is the one. If we are not, before extensively investigating, we need to ask them to bring all the available drugs, not that they are using, but the elder people are using. So that is one cheap way of finding out an unknown cause for hypertension. this is from my personal experience. So I thought I will share. Thank
good.
you very much for that extensive
Yes, we had a
presentation.
patients on cyclosporin, actually cyclosporin producing sudden severe hypertension and hypertensive emergency. That
Yes,
is
madam.
child
And
with
tacrolimus.
tacrolimus.
Yes, both all these liver transplant, renal transplant,
Yes, yes.
all these children with the transplant also we need to check the levels of this tacrolimus and all to find out. It might be one cause. They might not be presenting as stress, but they will be presenting at agitated state.
Yes.
Irrelevant
Behavioral
speech.
alterations and
Like that. Yes, yes.
thank you, Bindu. Nice to hear from you. And Dr. Benno? Dr. Benno, please. Benno is there? No, he's not there, it seems. Okay. Is there any other questions? Sujit, can we stop?
Yes, madam. Actually, announcement.
This time we had very young group, so we'll again give them more and more chances.
Kalpana, I am very happy to see old KIMS alumni, young KIMS alumni presenting so well. So it gives me a lot of
It is your training,
satisfaction.
sir. It is
Yeah,
your training that they're
maybe
doing.
God's grace. But I am so happy to see them both doing well.
Thank you, sir. And they are actually made to speak in KIMS. That is a change that I have seen. Many students who were not at all speaking anything, towards the end of the course, they'll be so active and interactive and presenting anything and everything. Thank you, sir, so much.
So
We can stop.
so then we can stop, madam. Actually, so I thank Dr. Arathi and Dr. Shaziya for their wonderful presentations, and we observed the World Hypertension Day in a wonderful way. And we had a very good contribution from Ashok sir and Purushottam sir, and enriched the whole session a very good teaching experience. So thank you all of other delegates who have joined today, and hope you to see you in the next session of Tuesday series. Thank you. Good night.